I'm Hendricks with the VCU Autism Center for Excellence, and I'm going to be talking today about screening for autism spectrum disorder. It's everyone's responsibility. We're going to be covering the following objectives during this presentation. What is screening? Why is it important to screen for autism spectrum disorder? Who should we screen? What is autism spectrum disorder? Just so we all make sure we know the characteristics and the warning signs. Whose role is it to screen? When should we screen? And of course, what is the screening process, and then what are the tools we can use in order to screen? First of all, I want to talk about what is screening, just so we have no misconceptions. And I'm going to read this definition just so we have complete clarity. Screening is the early identification of children at risk for cognitive, motor, communication, or social emotional delays that may interfere with expected growth, learning, and development, and may warrant further diagnosis, assessment, and evaluation. So screening is all about identification, identifying those warning signs, those red flags, and then of course moving that child on to diagnosis or assessment should those warning signs be present. There are different types of screening. Number one is general developmental screening, where we're looking for general delays in development. But then what we're going to be talking about specifically today is autism spectrum disorder screening. So next, let's talk about why we screen for autism spectrum disorder. When we screen, we can identify those children with red flags and then again move them on for evaluation, which may or may not lead to a diagnosis. But if we're screening and we're identifying those red flags and those warning signs, we can move them on into early intervention services. And we know early intervention is very critical for any child with autism spectrum disorder or even with any sort of general developmental delay. Early intervention has been proven to make significant gains in things such as language, communication, social functioning, and then of course just overall development. So the sooner we can get a child into early intervention, the better. And one of the other things I want to point out, there's been much research lately on how early intervention can also make striking changes in the actual structure and functioning of the brain. This is really important because we know during the first years of the child's life, the brain is very malleable. It is still developing. And if we're providing early intervention services, we can actually help reinforce connections in the brain, break down some of those connections that aren't useful to the child, and as I said, really make some changes within the brain itself. You will see one article cited here by Voos et al. In 2013 that provides some information on this. And as I mentioned, there's several other research articles that's demonstrating this as well. And these brain changes can lead to significant improvements in behavior, in social perception, communication, and then again, that overall brain functioning, making it much more effective and much more efficient. So next we're going to move on to who should we screen? And the answer to this is simple: every child. It is recommended that all children at ages 18, 24, and 30 months are screened. Now this includes all children at all racial, ethnic, and socioeconomic backgrounds. We know that autism does not discriminate. It does occur across all of these groups. And then of course we need to screen both boys and girls, and this might be a misconception because we know autism occurs more in boys than it does girls. There's about a 4-to-1 ratio, but it does impact girls, and sometimes we overlook that group, so we have to be very cautious of that. We should also be screening children who have risk factors. One of the things with screening is that it's not a one-time ordeal. We don't screen once and say, okay, we've done our job, let's move on and let the child develop as he or she will. But instead we have to continually screen. As I mentioned, 18, 24, and 30 months are the recommendations, but we also have to think about risk factors. For example, if that child has a sibling with autism spectrum disorder, we want to keep a closer eye on that child and perhaps consider more screenings or doing them at different intervals. Another risk factor would be being born prematurely, and we want to keep a close eye on that child as well. Next, we have children who present with red flags. As that child develops, let's say that you do a screening at 18 months, and then all of a sudden, somewhere around 20, 22 months, as that child is developing, you might see some different types of red flags appear. So for example, as that child develops, you might see a delay in language, or you might see the lack of joint attention really start to be noticeable. You might also see more presence of behaviors, atypical behavioral patterns such as finger flicking or toe walking, or other sorts of behaviors that are indicative of autism. So, be sure to look for those red flags as well. And then finally, when there is a parental or professional concern. So if you have a parent, if you're a pediatrician and you have a parent come to you and the parent says, my child is not talking, or she plays alone at childcare and doesn't interact with the other children, those are some parental concerns that you'll want to be aware of and really take very seriously and consider doing a screening at that point. If you are an early intervention provider or a child care provider or some home visiting professional of some sort where you're in the home and seeing those things and you're talking to parents and they're sharing those concerns, again, take those seriously and consider doing a screening at that point as well. Now we have some numbers on the prevalence of autism spectrum disorder. 1 in 68 children are now believed to have ASD. These are numbers released by the Centers for Disease Control, and you can find information on that stat at the link provided here. This is very alarming, and so it really speaks to the need to make sure we're screening, so we're identifying children at a very young age and again moving them to those intervention services. So I mentioned we would talk a little bit about what is autism spectrum disorders. And I have provided here the Center for Disease Control's red flags for autism spectrum disorder. And you can actually go onto this website and you will find linked to our website these red flags. So you can download them, you can print them, you can have them accessible so that it's easy to memorize, easy to remember. But some of the red flags that are very common would include such things as not responding to their name by 12 months of age. Not pointing at objects to show interest. So for example, an airplane flies overhead, a 12-month-old, a 14-month-old might be pointing to it to show it to you, and a child with autism spectrum disorder may not share that sort of interest. Not playing pretend games. So pretending to drink from a cup, pretending to play with a doll or to feed a doll, pretending to put gasoline in a car that they're driving around a track, those sorts of things might be absent. Of course, eye contact or wanting to be alone. Having trouble understanding other people's feelings or understanding their own feelings. Delay in speech and language. Repeating of words or phrases over and over again. This is also called echolalia. So you might ask the child, do you want a cookie or cracker? And the child repeats back, cookie or cracker, as opposed to answering the question. Or that echolalia might be delayed. So in other words, they might hear a movie line or a commercial on the television and then repeat those phrases over and over and over again. So this can have several different looks to it. Giving unrelated answers to questions. And then some behavioral indicators, getting upset by minor changes. In other words, the need for sameness. The schedule needs to look the same. I need to drink from the same cup every day. You must park in the same place in our driveway every day, take the same route home. That need for change is very ingrained and very strong. And so when there's any sort of changes, that leads to major upset. Obsessive interests, really liking something to a point that it's really interfering. So for example, having a favorite red train that has to be carried around all the time, and if that red train is lost, it leads to major upset. Or having a topic of interest. So for example, loving dinosaurs, that it's only movies on dinosaurs and books on dinosaurs and things of that nature that the child is interested in. And then finally, flapping hands, rocking, so motor mannerisms that might be occurring. And then unusual reactions to the way things sound, smell, taste, look, or feel. In other words, different sensory responses. So you might see a child covering his ears because the noise is too loud, but yet the next minute turn the TV way up so that they can hear that commercial a little bit louder. Maybe being a very picky eater because of the way things taste, or perhaps even smell and wanting to keep those things away. Having an aversion to bright lights, so covering eyes. or maybe liking the way light moves, so staring at fans and staring at lights that flick and move around and those sorts of things. So that sensory piece can look very different from child to child. Now the CDC provides red flags, but we have provided some other red flags because, as I mentioned, screening is not a one-shot ordeal, that we have to continue this throughout the child's development. So we have provided some other red flags that are a little more subtle, especially for those children who might not demonstrate these characteristics until they're a little bit older, maybe until they're after 24 months of age or after 36 months of age. It doesn't mean that autism wasn't present from birth, it just means those characteristics are more obvious as they get older and as their development grows and as their social world expands too. So some of these characteristics include imitating actions of others. Imitation is something we do at a very young age. It's part of our learning process, so if you see that absent, that's a red flag. Playing interactive games, playing with a variety of toys, or play is very repetitive. So in other words, it's only the same set of toys that are used every time. It's always the same train set, or it's always the same doll and stroller. Or that repetitive play, so when the train comes out, it's always driving it the same way around the track. Or if that child likes playing with blocks, it's always building the same tower, knocking it down, building the same tower, knocking it down, so it becomes very, very repetitive. Not following simple instructions, and this can look like the child is ignoring you. It can look like the child is deaf. It can look like the child is being obstinate, but sometimes it means there's a delay in that receptive language and they're not understanding, and so that's why we might see difficulty with following instructions. Unable to talk about a variety of topics. Now we're talking 2 and 3 years old, so we're not talking about in depth, but in other words, not obsessing about one area of interest, as I mentioned before, dinosaurs or cloud formations or something of that, or trains or something of that nature, but instead being able to have a variety of conversations and answer questions on a variety of topics. And then finally, does not seem to know the function of common household items, so needing some assistance to do such things as get ready for bath time or put shoes on or get shoes in order to go in the car to go on a trip, and those sorts of things that we would expect of a 2-year-old moving on into being 3 years of age. What I want to do now is highlight some of these characteristics. Dr. Rebecca Landa from Kennedy Krieger created this wonderful video about bringing the early signs of autism into focus. So let's take a moment to look at some of these characteristics in young children.
I'm Rebecca Landa, Director of the Center for Autism and Related Disorders at Kennedy Krieger Institute. You are about to watch a brief tutorial illustrating the early signs of autism spectrum disorders, or ASD. You will see 3 pairs of videos of 1-year-olds. Within each pair, you will first see a child with neurotypical development, followed by a child who shows early signs of ASD. The developmental features indicative of ASD shown within these videos fall into 3 main categories. These include effective communication and sharing enjoyment, making social connections, and the one with which we will begin, seeing social opportunity through play. This 19-month-old child does not show signs of ASD. He has chosen to play with the balls. He quickly integrates the lady into his play. He pretends that the balls are food and offers a bite to the lady.
He pretends a lot of stuff is food, and he always wants you to eat it.
To you. Okay. You're making some yummy food.
He understands that food, spoons, plates, and eating go together.
Yummy.
As he creates a pretend play activity, he remains aware of the people nearby. He enjoys incorporating social interaction into his play and offers the lady a bite.
Thank you. That sure is tasty.
He is able to pay attention to the lady, the doll, and the pretend food all at once. He shares his excitement about the toys with the lady, looking at her and smiling. After the lady comments that the food is hot, he links his play and language to her idea.
It's okay now. It's cool. It's nice and cool now. Yeah.
Here, he imitates the lady's action with the pretend lipstick.
Oh, my lips are pretty now. My lipstick on. Oh, it doesn't come off.
This helps him to learn new play skills and at the same time synchronize his actions with the actions of others.
Yeah, she has lipstick on. Oh, just like Mommy wears. You look so pretty. Thank you.
This 19-month-old child shows signs of ASD. He has an intense interest in the toy phone. He does not share his enjoyment of the phone with others. He does not look toward others and smile.
Shells, sensory, all kinds. He really has this addiction to telephones lately, though. It's okay, though, because it's helping him to make sounds, so there's probably like 10 telephones laying around my house, because he walks around carrying them and sits them down, and then he goes on to the next one.
Although he puts the phone to his ear, he does not show creative play with the phone. When his name is called, he does not respond.
Elliot. Ellie. Ellie. Elliot.
He does not offer the phone to others so that they can have a turn.
He would turn to his name, and progressively he's not.
His mother tries to distract his attention away from the phone.
Let Mommy see the phone. Let Mommy see it. Let Mommy see the phone.
Are you being difficult now? Are you being there? You are.
She begins to tickle him. Although he seems to enjoy the tickling, he does not look at his mother or make a social connection with her. He does not try to communicate with his mom to keep the social game going. This 14-month-old child has a mild motor delay but does not show signs of ASD. As he explores the new toy, he remains aware of the people nearby. He checks in with his mother behind him to ensure that she also sees the toy. Next, he shows that he understands the social communicative meaning of the woman's pointing gesture by immediately looking at the sticker. Then he looks over at another sticker she had pointed out before. He continues the woman's topic of communication as he points to the Tigger sticker. He shows the motivation to maintain social engagement with others and the ability to communicate using coordinated gaze, vocalization, and gesture. This 14-month-old shows signs of ASD. First, he flaps his hands while enjoying the bubbles. He does not share his enjoyment by looking at the man. He does not respond to his name.
Ben. Ben. Ben.
Although he looks at the man's pointed finger, he does not follow the direction of the man's gesture to locate the object of the man's attention. This 14-month-old does not show signs of ASD. While she enjoys looking at and exploring the toy, she stays engaged with the people nearby. She tries to share her enjoyment with her mother as she turns to show the toy to her. Then she shares her enjoyment with the lady across from her by directing her gaze and smile toward the lady. Also, she recognizes that the lady is a source of help. Her request for help is clear and effective. Coordinating eye contact, gesture, and vocalization for purposeful communication is a sign of healthy social and communication development. This 14-month-old child shows signs of ASD. Notice how his attention is so focused on the toy that he does not interact with the people nearby. He does not share his attention with others. His exploration of the toy is also unusual. He drops the toy onto the table and watches it move. When the toy stops moving, he does not use eye contact, vocalization, or gesture to ask for help. He also tenses his body and mouth in an unusual way.
Want to do it again?
Even though the lady is talking to him, he shows no interest in her. He does not seem to understand that her gesture is an offer to help him. He does not check in with the lady or his mother to see whether they are paying attention to the toy that he is enjoying. ASD is a neurodevelopmental disorder affecting multiple aspects of development, especially social and communication skills. Children with ASD often show unusually intense interest in certain objects or sensory experiences. They may repeat certain behaviors over and over again. The signs of ASD are not transient, but rather persist over time. The earliest signs of ASD are often subtle and become clearer in the second and third year of life. A diagnosis of ASD should be made by one or more experts who gather a thorough developmental history, directly assess the child's developmental abilities, and conduct a medical exam. For more information about ASD early detection and intervention, or to sign up to receive our newsletter, please visit autism.kennedykrieger.org/card.
So whose responsibility is it to screen? Well, the answer to this is everyone's. It used to be believed that it was largely the pediatrician's responsibility, and it is. As you can see from this visual provided here, we still put much of the onus on pediatricians. It is a responsibility during those well-child checkups to provide the screening, again at those same intervals, 18, 24, and 30 months. But we also know that this is an all-hands-on-deck issue, and so we include others in the responsibility to screen. Parents and guardians, being aware of the child's development and sharing concerns and taking those to the pediatrician should they exist. Early interventionists and home providers having a responsibility in this. Child care providers, sometimes they are the first professional to really see that child in an active social setting. And then, of course, any other professional who comes into contact with a young child. It is so important for us all to be involved in the screening process that the CDC created the Autism Alarm. And again, you can find this on the CDC website as well as our website. But ALARM stands for Autism is Prevalent, Listen to Parents, Act Early, Refer, and Monitor. And this is something else that would be helpful to have posted in your office, to share with your colleagues, and to make sure everyone is up to speed on the roles and responsibility in the screening process. So let's break these people down. Let's break down the roles of these different professionals. So first of all, with the pediatrician, again, we've talked about 18, 24, and 30 months, the recommended times to do screenings. And of course, if red flags exist, perhaps the pediatrician is noticing this in a visit, or the parent comes to the pediatrician with a concern. But one of the things I want to note here is that we're finding that not all pediatricians are screening. And so nationally, what we're finding that the average age of diagnosis is 4 years of age or older. And in Virginia, it's actually older than that. And that is not okay for the development of these young children, as we've already discussed. So we want to make sure that pediatricians are really involved in this process. Now let's look at the role of the early intervention provider or the home care provider, and that can be a myriad of different people providing different activities and responsibilities in homes for young children. But we know with this group, one of the parts of their responsibility would be case finding. So in other words, conducting routine surveillance to be looking for any sort of signs of atypical development in young children with whom they interact. And then of course, recognizing those risk factors and identifying those warning signs, that that's a a complete responsibility of early intervention providers and home service providers. But that responsibility also extends into the screening process. And so as an early intervention provider or a home service provider, also ensuring that you're conducting the screenings as you need to. And I do have some recommendations for this. Certainly what I would like to recommend is that if a child is referred to early intervention services, upon intake, when you're doing the initial assessment process and before the IFSP is written, do a screening with the child. Do a screening with every child who comes through your doors. That's one way that we can make sure children are being screened for autism spectrum disorder. I have worked with early intervention agencies where that is their policy and that is occurring, and I think that that is a very strong policy and a way to proceed. Some other suggestions, however, would be when red flags are observed. So again, upon entry, as you're doing that initial observation with the child, if you see any of those red flags that we talked about, any of them, then that's when you do a screening. You pull out the screening tool and you do it. And then another suggestion, still, I'm giving options here, is to provide that screening at target ages of 18, 24, and 30 months for all of your children under your care. So there's different ways that we can go about this to make sure you're involved in the screening process as well. Now with the child care provider, again, that case finding, making sure you're identifying any children who might have atypical development and recognizing those risk factors, and then being able to communicate those concerns with parents in a timely fashion, in a sensitive and timely fashion. Again, there is a responsibility with screening here, and I realize we're talking about a different set of professionals with child care providers. As I mentioned, often the child care provider is the first professional to see a child in a social setting, to see him or her interact with other peers, to see him or her try to adapt to group dynamics and those sorts of things. And so the child care provider can really see some very different behaviors and responses, and so it puts you in a really nice situation to be able to look for some of these red flags and to provide screenings. My recommendation for the child care provider is if you see the red flags, if you see the warning signs of autism, use the screening tools to verify your observations. And so you can say, I see 2 or 3 of these red flags, I have a concern about Jacob, and so then that's when you pull out that screening tool. You do the screening tool with that child, and then if you have your observations verified, then you have an objective tool that you can then work with the parent and talk to the parent and have more solid information to share with him or her. Now, only a small percentage of pediatricians report screening specifically for ASD. A much higher percentage do report doing general developmental surveillance, but as you can see here, only about 8% are reported to do screening for autism spectrum disorders. And there's a lot of thoughts on why these numbers are so low. The most obvious being time restraints. There's a lot going on in those child visits, and so certainly the time limitations can be an issue. Some of the other concerns, though, or some of the other reasons might be there's a let's wait and see mentality. Throughout my entire career, I have worked with family members, and the number of times I have heard family members tell me that the pediatrician said to them, let's wait and see, we'll give him some time to develop, or it's a boy, they tend to develop a little slower in some of these language areas and communication-based areas. And that's not a good mentality for us to have. Time is too precious for these young guys and girls, and so the wait and see is certainly not a good strategy. We need to go ahead and screen and verify whether anything is going on. Next, we have misperceptions about ASD and characteristics, that there's a lot of stereotypes out there, and so things like a pediatrician or an early intervention provider or a child care provider might believe, oh, he's too social, he likes people, so therefore he cannot have autism. And that's not true. Many of our guys and girls with autism are very social. They're just not apt at those skills. Also, they might say the language is too high, he talks too much, therefore he can't have autism. Or perhaps he has eye contact, he can't have autism. And so there's many misperceptions that can also dissuade professionals from screening. Reimbursement concerns. how do I get my time paid for when I'm in the office? And I'm going to talk about that very issue in just a couple of minutes. And then finally, the fear of parental response. And this is a very real issue, whether you are a pediatrician, an early intervention provider, a child care provider, knowing that the parents aren't always ready to talk about this, that certainly no parent wants to sit down and have a conversation that means that their child has atypical development of some sort and possibly even autism, that's a very frightening conversation. But in working with parents over the years, certainly I have never heard a parent say, I wish it had taken me more years to get a diagnosis. I have never heard a parent say, my doctor should have lied to me all those years. And I have never heard a parent say, I wish no one had told me they had concerns. If I could reverse these words on the screen, I have had parents say, I wish I had a diagnosis earlier. I wish I had known there were concerns earlier. The word earlier is always applied, and certainly while there's no easy way to have those conversations with parents, they need to be had. They deserve honesty, they deserve answers, and their child deserves the opportunity to go to early intervention. Now, I mentioned I would talk about reimbursements, so there are codes that you can use as a pediatrician, as a medical provider, in order to be reimbursed for the screenings that are conducted. So this is for developmental testing limited. So this is with interpretation and report. So here's a code, and then finally for developmental testing extended, there's also a code for that. So sometimes we do the initial screening and we don't have the answers yet, so we have to extend that a little bit farther, and so there's a code for that as well. Now finally, we've already talked about the wait and see approach versus intervention. If we wait and see, there's a delay in services, poor outcomes. Parents live without answers. And then there's financial implications, meaning if we don't provide those early intervention services that are so important and can lead to so many gains, that we do see that extend on into elementary and middle, high school, and then adult years as far as the number of services that are provided. There's a lot of reports on this that we can look at to see that there are financial implications. And certainly with intervention, we have better outcomes, better services, and better outcomes. So now I want to share with you the process for screening, and this document was available to you on the website as well prior to viewing this presentation, and if you didn't have a chance to download it, you can go back and do so. This is the Virginia process for screening for autism spectrum disorder. You can see on the far left-hand side a column indicating all of those reasons why we screen, and I've gone over those, but to review, the primary care physician has concerns. The parent or guardian has concerns. Another professional has a concern. And then finally, the child has a sibling with autism, child was born prematurely, and of course the age of the child, 18, 24, or 30 months of age. From there, we move on to the tools that we used for screening, and we're going to talk about those tools in just a couple of minutes. And then, of course, what we do when that screening result is positive, in other words, there are red flags for autism present, and then what we do if it's negative. And I really want to focus on if it's positive, what we're going to do is if we need to rescreen, we can. We don't always have to do that, but sometimes there might be a reason why we want to rescreen. Perhaps we feel that the parent didn't understand the questions. Maybe there was a language barrier. Those might be some reasons why we would want to rescreen. The second thing we'll want to do is certainly rule out a hearing impairment. And so hopefully at this point there's been hearing testing done, but if not, we want to do that. And then we want to refer for a diagnostic evaluation. Next, we want to refer to services and supports. Now that might seem like we're putting the cart before the horse, but we are not. If a child screens positive for autism spectrum disorder, there's likely some sort of developmental concern. It may not always be autism, but very often there's some sort of concern that will warrant intervention services. So just keep that in mind. And what we want to do is refer them on for services and supports, because with every service entity, there's an assessment that has to be done before they can begin services. That's time consuming, and so we want to get that ball rolling so we're not wasting any more of the child's time. And then, of course, we want to plan for next steps with the family, really helping them to move forward so that they are setting up the appointment for the diagnostic evaluation, setting up the appointment with early intervention or the school so that they can begin those services, and then planning to come back to your office if you're a pediatrician so that they can continue working with you as part of a team. All right, we're going to switch over now and talk about those screening tools. The first one I want to introduce you to is the Ages and Stages Questionnaire 3. Now this is a general development screening tool. This is not specific to autism, but I want to talk about this because number one, this is a tool used in Virginia for general developmental surveillance. A lot of pediatricians use it, but it's also used within the early intervention system. It has an age range of 1 to 66 months, and you can see here on the screen that it looks at a variety of areas including communication, motor, problem solving, personal, social, and so on. So it's really a comprehensive screening tool. It takes about 10 to 15 minutes to complete and under 5 minutes to score. And one of the nice things about this tool is if you want a hard copy of it, you do have to order it, and it does cost. There is a cost associated with it. However, there are options online that are free. For example, Easter Seals provides it online for free at the link provided here. You can actually go in, put in just a little bit of information such as the child's date of birth. It will give you the right ages and stages pages, and you can go to that and basically fill it out based on the child's age, and then it will send you the score. So it's a really nice service that is for free that you can do. You can have parents do in your office, you can have parents do during a home visit, and those sorts of things. So it's a really nice option to do general developmental screening. On the next two slides, we're going to be looking at screening tools specific for autism spectrum disorder. Now you see here the modified checklist for autism in toddlers, RF, the R stands for revised, the F stands for follow-up interview, or what we call the MCHAT RF for short. This is really the gold standard tool that we want to use for screening children with autism. There's a lot of reasons for it. The sensitivity, specificity, the validity of this instrument are the number 1, 2, and 3 reasons why. But also it's free and you can get this online. That's a real plus. But it also really does a nice job of identifying those children on the spectrum. This particular tool is appropriate for children within the age ranges of 16 to 30 months. And that's that time that we're really wanting to identify this disorder, okay? 16 to 30 months. So that's another reason why this tool is so helpful. It takes about 10 minutes for someone to fill out. Everything is a pass-fail question. There's 20 total questions in this new revised version. Parents can fill it out on their own. So you can send them the document. You can send them to a website. There's actually a website where the MCHAT is housed that you can send them to and they can complete it. And then in your office, during the home visit, depending on what sort of professional you are, you could then go over the results and ask more questions should you need to after they fill it out. Or you can sit down with the parents and go through each question individually. So there's different ways that you can use this tool. The next one is the Pervasive Developmental Disorder Screening Test 2 Primary Care Screener. It's quite a mouthful, of course, but this is for children 12 to 48 months of age. So you see it extends it up to 48 months of age, which is important because we have to think about covering all the age spans in children as we identify screening tools. Again, parent questionnaire, you can ask a parent to fill it out on his or her own, or you can sit down with the parents and do it with them. Everything is yes, no, 22 questions, about the same amount of time, 10 to 15 minutes to complete. And one of the things with this tool is it does have a cost to it. It is something that has to be purchased. Next, we have the Childhood Autism Spectrum Test, or the CAST. This used to be called the Childhood Asperger Syndrome Test. So be careful if you're downloading this because it is free and online. Make sure you get the right one. This is for children 4 to 11 years, so it's really school-age children. So again, unfortunately, we're not identifying all of our children before the age of 24 months, 36 months when we would like to, and so it's important to have a screener for those older children as well. If you look at this tool, you'll see that it's very language-based, so it's looking at those school-age skills, very language-based, but it's also very behavioral-based too, looking at atypical behavior, so this makes a very strong tool for this age group. Again, about 10 minutes to complete. There's 37 yes-no questions that are to be answered. Next, we have the social communication questionnaire. This was developed as part of the ADI-R. It's a modification of that diagnostic tool that they turned into a screener, and so it makes a really nice tool as well. It is for 4 years and older with a mental age of 2 years or older, is how it's described. There's 40 yes-no questions, again about 10 minutes to complete. Pass-fail is used. So you see all of these have some consistencies and about the number of questions, how long it takes. They're yes-no questions for parents. Again, you can sit down with the parents and do it with them, or they can do it on their own. Again, this one does have a cost, so you have to keep that in mind, but this is a really nice tool, and all 4 of these are tools that we recommend. There are other screeners out there, but these are the 4 that we recommend to cover the age span of children so that we can make sure we're screening everyone. Okay, and now you are ready to screen.